evening, and thank you for joining us. My name is Heather Forgione, and I am the Program Manager for the Women's Heart Initiative at the Lankenau Heart Institute. The Women's Heart Initiative is a dedicated program across mainline health focused on educating women to be aware of heart disease and its associated risk factors. Our mission is to encourage women to learn the truth about heart disease and the risk it poses, and to use this knowledge to make informed decisions with healthcare provided to get the best and equal treatment to live healthier lives. We're all here tonight to discuss an important heart health topic, understanding skipped heartbeats, flutters, heart arrhythmias, and palpitations. It is my pleasure to introduce Dr. Maribel Hernandez, cardiologist with a subspecialty in electrophysiology for the Lankenau Heart Institute and medical director of the Women's Heart Initiative. After the lecture, we will have a question and answer session. And without further ado, I would like to introduce you to Dr. Maribel Hernandez.
Good evening. I'll be getting my slides ready here. And thank you everybody for joining us tonight. This is a very important heart topic and a very common problem. So I'm going to review the agenda for tonight. I always like to start with the basics to understand the anatomy of the heart and the electrical system. I will discuss different types of arrhythmias, the different symptoms that people may have, how to diagnose if you have an arrhythmia or have suffering from palpitation, how to make the diagnosis, what are the different causes of arrhythmias, and what are the option treatments. So to start, in general, to remind everybody that the job of the heart is to pump blood around to the entire body so that it can deliver oxygen and nutrients to the body. And so it's really a critical function so that we can, all the organs of the body get enough oxygen, the muscles, the brain to function properly. So the heart is a structure that has many different components. And each of you can have problems, heart problems from every different types of the parts of the heart system. In general, the most common one that people are familiar are heart attacks. And as you can see, I'm showing you, this is the aorta, by the way, that sends the blood from the heart beats, sends the blood up to the aorta with oxygen to the brain, the heart, and to the entire body. But most people are more familiar with heart attacks. And here you see the coronary arteries on top of the heart muscle. And when those get blocked, that's when people have heart attacks. The heart has two top chambers called atrium and two bottom chambers called ventricles. Right atrium, right ventricle, left atrium, left ventricle. However, the heart has an entire electrical system. And that's why we have my specialty of electrophysiology. We deal with problems with the electrical system because you can have the perfect heart, like having a new computer, but if you don't have electrical activation or power so that the heart can beat and pump blood, the heart cannot function properly. So I'm showing you here some of the most important electrical pathways in the heart. And however, the entire heart has to have electrical fibers. But these are the key components, and you get electrical fibers branching from these key pathways. One of the most important one is called the sinoatrial node. These are specialized fibers that are called literally the pacemaker of the heart because it is the one that initiates the heartbeat. And if this has to initiate the beat and send the electrical signal to both atrium And then this electrical signals has to go through this very important structure called the atrioventricular node. And everything has to go through here. And these are the two important pathways. And I'm going to show in another image, again, the sinoatrial node that in between structure, the atrioventricular node, and sends electrical pathways to down to the ventricle. And if there's any problem with any of these major electrical pathways, people can have symptoms. Another important, before we go into definitions, I want to say that those electrical fibers are very sensitive to the autonomic nervous system, to the adrenaline, when there's stress or the fight and flight, the body releases adrenaline. So the heart has to respond, increase the heart rate. And it also is very sensitive to the parasympathetic nervous system to slow the heart rate. For example, at night, the body releases acetylcholine, it slows the heart rate. So these electrical fibers are very responsive to changes in the autonomic nervous system, and because they really have to adapt and send, increase the heart rate, send more blood flow to the body to meet the needs of the body. I want to quickly review some terms. A lot of my patients in the office ask me, what does it mean? And these are terms I'll be using in the talk. And an arrhythmia is simply an improper beating of the heart. It can occur when those electrical fibers I show you do not work properly. Bradycardia means a slow heart rate, usually less than 60. The normal heart rate is between 60 and 100. Tachycardia is when the heart rate is fast, greater than 100. This is the normal range is 60 to 100, but people like athletes, people who exercise a lot, who are well conditioned, they tend to have a resting heart rate in the 40s or 50s. Now, palpitations and arrhythmias are very common. Most people experience palpitations or pounding on the chest at some point in their lives. Most of them are benign. However, some of these palpitations and arrhythmia may be a manifestation of maybe the first manifestation of an underlying heart problem, or people may have potentially serious, dangerous arrhythmias that need to be diagnosed and treated. It is normal to have occasional fast feeling of fluttering, skip beats, irregular beats. I will explain all of this more during the talk, but people describe it in many ways. Some people feel a pounding, some fluttering, which might be quick or might last a long time, irregular heartbeat. So everybody uses many different terms, but the main message is that it's normal to have occasional palpitations or occasional extra beats. There are different types of arrhythmias, and I will show you. And depending on the type of arrhythmia, there are different types of treatments. So the more common one is the ones we call premature, which are early beats. So coming from the atrial, the top chambers, electrical fibers, or early or premature beats coming from the bottom chamber of the heart or ventricular. What is important in terms of the electrical system function is that the heart functions much better when it's activated in an organized way, so that the top chamber activates first and the bottom chamber follows the top chamber. Is one-to-one relationship. If one of the electrical fibers start activating too soon, the valves in the heart, and the heart cannot pump properly because it's completely out of sync. So some of the more common are single beats, single atrial beats, single premature beats, atrial arrhythmias, which are from the top chamber of the heart, supraventricular tachycardia, and atrial fibrillation. Atrial fibrillation is very common, especially after age 65 years old. Here, this is a diagram of the heart. I know the heart is faint, the coloring, but this is the right atrium, right ventricle, left atrium, left ventricle. And this is what I mentioned, the sinus node, AV node, and the main pathways. So people can have electrical tachycardia, very fast rhythms, which originate from, sometimes people are born with these extra electrical fibers. For example, this one is very common in women, especially younger women and teenagers, where there's a little extra tissue and the electrical circuit starts going around and around and around, and it starts this fast rhythm. There are other people are born with an extra electrical connection, and they develop some this tachycardia down here. And it has a big circuit. So these are called atrioventricular reentrant tachycardias. It's not uncommon to have one spot only that starts firing. And sometimes it could be a single premature beat, or it could be a single focus down here in the ventricle. But sometimes there's one spot that keeps firing and going fast. Here in the left atrium, these are 4 pulmonary veins that bring the blood from the lungs into the heart, the blood with oxygen. And that's where atrial fibrillation, which originates, but it spreads to both atrium, and it's a chaotic electrical activity. And you'll be seeing more, I'll be telling you more about it. So those are some of the most common arrhythmias. These are an electrocardiogram or heart rhythm strip, which records the electrical activity from the top and bottom chambers. And here, this is a normal beat, small signal for the top chamber, followed by a larger signal from the ventricle. Atrial activity, ventricular activity, and then the heart rests. So this is going at a normal rate, but suddenly there's an early beat, and that should not be there. It's just one electrical fiber in the atrial, in the top chamber, decided just to activate early. And then you see there's a pause, and that's why people sometimes feel a skip beat, because they don't feel this electrical activation, they just feel like a pause. And that's when people describe skip beats. Most of the time it's not skip beats, it's that there's an early beat, the heart likes to reset and start all over again for the top chamber. There's a resetting, which is normal. And these are the premature beats from the bottom chamber. The signal is larger and different. And these are called premature ventricular beats. And as you can see, there's a pause. So it can feel like pounding and a pause. And that's part of the heart normal physiology. I wanted to say a little bit more about these beats. Premature beats are especially ventricular and also atrial, but this can be more symptomatic because it's the ventricle, it's bigger structure and sending sudden blood rush to the aorta, so it feels like a pounding. And these people can feel it on and off, and this rhythm is usually, most of the time, is benign, but it can be really bothersome, very annoying, as you can be lying in bed, and when you're at rest, usually people can feel more their heartbeat, and they can feel this, it could be pounding, a flip-flop, a flutter. Now, most of the time, we do not treat these extra beats. The majority of people can have them and are not, they might be annoying, but are not dangerous. there's a small group of patients that they have so many of these that they get short of breath, they get dizzy, lightheaded, that they really need treatment with either medication or catheter procedure, which I will show later, that can find the abnormal electrical activity and eliminate the extra beats. Many times we treat with beta blockers, but even though they are annoying, these are considered benign. I want to talk about one of the arrhythmias that is called supraventricular, which is from the top chamber. As you can see, it's one of those arrhythmias that I showed earlier in the other diagram. And this is, as you can see, very fast rhythm. And it's a very common arrhythmia in women. And people have totally normal heart. They have a primary problem with electrical, that usually additional electrical fiber that causes this rhythm. And this is an arrhythmia that is curable with that procedure called catheter ablation, where a catheter is put inserted in the heart. And then you find the spot that is causing the abnormal electrical activity, you burn it, you cauterize it. And this is one of the few rhythms that you can avoid, you can treat with medications, but it's more than 90% success rate with a catheter procedure, and people are cured. I have took care of many young women, some of them that they were having a lot of problems coming to the emergency room. They get dizzy, lightheaded, and their life completely changed after eliminating this rhythm. But it's a very common rhythm in women. So I want to talk a little bit about what is atrial fibrillation. Atrial fibrillation is, as I mentioned, this is the left atrium, there are 4 pulmonary veins. The electrical activity around these veins becomes very active, chaotic, and it spreads through the electrical fibers to both chambers. So the normal activation, as I mentioned earlier, this is what the heart works well. When you have the top electrical signal starting and sends the signal down the AV node. So this beats first, rests, sends the signal to both chambers, the heart beats and sends the blood out to the body. But this is the signal from the atrium and then the ventricle. And this is what the heart likes. The heart likes one-to-one relationship. What happens is that this chaotic rhythm, it sends chaotic signals to the ventricle, and it becomes very, very irregular. And patients feel like fluttering in the chest, they can feel pounding. But it is an abnormal electrical chaotic activity from the top chambers. One of the reasons we've mentioned this rhythm is because this rhythm is associated in some patients, not all, with the potential for stroke. Not everybody's at risk from stroke for this arrhythmia, but patients need to be evaluated when they have this arrhythmia and be treated if they may be at risk for stroke. This is an electrocardiogram of the atrial fibrillation. It's very irregular rhythm. So now I'm going to mention arrhythmias that are from the bottom chamber of the heart, ventricular. You can have, as I mentioned, benign arrhythmia, which are single beats from the ventricle. But most of the time, these arrhythmias, when they are sustained, tachycardia, and sustained for minutes, in patients who have a weak heart muscle, heart failure, heart attack, severe heart disease, this is the type of rhythm that can cause a cardiac arrest. Again, fortunately, this is not very common. And when we see this dangerous rhythm, it's usually in patients who already have severe heart disease. We have some young patients with normal heart that can have this arrhythmia, and even if they get it because they have normal heart, they do very well with treatment. But patients who have this rhythm with severe heart disease, it could be it's a dangerous rhythm that needs treatment. And this is an example of, you can see this very fast, chaotic rhythm from the bottom. And what happens, the heart doesn't have time to fill up with blood, and then it stops sending blood to the aorta. It's too rapid, chaotic. And this rhythm may lead to cardiac arrest. So those are the ventricular rhythms. So we went through the top chamber rhythms, supraventricular, ventricular rhythms. And then we cannot forget that some patients have very slow heart rates. And most people can handle heart rates in the 40s without any problems, without any symptoms. But it's very common in patients who are athletes or who exercise regularly to have a low heart rate, 40s, down to the 40s, sitting down at rest. As long as when they can exercise without symptoms, we don't do any treatment or insert pacemakers. It's normal to have a slow heart rate during sleep. So during the day, when you're active, the heart rate is up. When you have a high adrenaline, the heart rate goes higher. But the body has a circadian rhythms, and the heart rate may go very low at night during sleep. And it's part of the normal physiology. This is an example of, what's called heart block, where you have more of these little beats here. There are more of them from the top chamber than from the bottom chamber. Means that the connection from the top to the bottom is not working. These patients get symptomatic and they need pacemakers. So problems with the sinus node, as I mentioned, can cause slow heart rates. And heart block, as I show you that picture, it means that some of the fibers stop conducting, and that's when you need a pacemaker. When patients get dizzy, they may faint. If the heart stops, of course, it's a cardiac arrest. But I want to mention that there are patients that have both fast and slow heart rates. And sometimes we have to put a pacemaker because to treat the fast, we need to be able to treat the fast. We give medications that slow the heart rate. So they can go from slow to fast. So sometimes we have to insert pacemakers so that it's safe to treat the fast rhythm. And that's not uncommon in patients that may have atrial fibrillation. The sinus node and the atrium doesn't work well and can go from slow to fast. So when we talk about symptoms, again, who should get an evaluation by a physician, a cardiologist, or someone in my specialty, cardiac electrophysiology? Again, if you have sustained, prolonged episodes that give you symptoms. It's okay to have occasional extra beat, fast beats, on and off. But if it's sustaining, lasting minutes, some people have it lasting an hour, nonstop. If it gives you trouble breathing, dizziness, fainting, severe fatigue, sometimes patients don't feel a fast heart rate, but they feel chest pressure, chest pain. They get short of breath going up steps. If you have any of these symptoms, you need evaluation. And I want to caution that in women, the palpitations, sometimes women are told that they're having a panic attack or you're having a fast heart rate because you're stressed or severe anxiety. Never accept this diagnosis unless you have been evaluated. And don't diagnose yourself with a panic attack or an anxiety attack. It's true that with panic attacks and anxiety, the heart rate will go up because adrenaline increases the heart rate. But it usually doesn't go up past 100 beats per minute, maybe 90s. If you start having a quick sudden onset of a fast heart rate that makes you heart pounding. You might get anxious because of it, but do not guess. Talk to the doctor, get a cardiac evaluation. And I have personally treated many women that have been treated with anti-anxiety drugs for panic attacks, and they really had an arrhythmia that was treatable. So how do we make the diagnosis? Depending on the type of symptoms, we use different tests. The first one is the electrocardiogram, echocardiogram, ultrasound of the heart. Sometimes we do stress tests. Sometimes the arrhythmia is only with exertion, so we want to see if we can get the arrhythmia under a stress test, or we want to make sure there's no problems with the heart. The echocardiogram and the stress test will give us information to make sure that you don't have a heart problem causing the arrhythmia. We know about heart monitors, Holter monitors, where you're attached to wires and the heart rhythm is recorded. Event monitors, there are different types of event monitors. The ones that you're wearing the monitor sometimes for a week, and it's continuously recording your heart rhythm. And we have others that only records when you have a symptom and you press a button and to record at that time. Electrophysiology study is a catheter procedure that we use to study the electrical system. This is the most common heart catheterization that people are familiar with, are the ones for blockages in the arteries. But this is to evaluate the electrical system and try to reproduce the arrhythmia and find out, and then if we can find the arrhythmia, it's an arrhythmia that can be treated, they can have the ablation procedure. I also wanted to make, this is an example again of atrial fibrillation, but I want to mention, going back, that one of the challenges with rhythm, these problems, is that they are intermittent and sporadic. So sometimes it's very hard to diagnose, because when you have the symptom at home, you have like 1 hour, 10 minutes, 5 minutes. Then you go to the emergency room at your doctor and you don't have the arrhythmia. And sometimes the symptoms may occur once a week, once every 3 months, sometimes once every 6 months, but they can be very severe. So it's very hard to sometimes to diagnose. So that's why we have, fortunately, we have much better technology to be able to diagnose and record this rhythm. This is one of the event monitors. I don't have a disclaimer. I don't have any financial interest in any of this monitors that I'm showing. But this is a small, sometimes people call it a chip that we put under the skin in the left chest, but under local. And this was developed, these monitors and records the heart rhythm, has a 3-year battery. And this was developed for people who faint or have rhythms that happen every 6 months or every 3 months, that you could no matter how many monitors you wear, it could not record it. And this has been a great technological development, because now when the person has the arrhythmia, we're able at that moment to document it. So this is inserted under the skin, very tiny with local, and patients have a home monitor wireless connection. This is at the bedside, and during the night, it communicates and downloads any data, any arrhythmia, whether you felt the arrhythmia or not. So this is for intermittent, sporadic arrhythmias that are significant. We also have, this is some of the new technology. There's an app. One is called Cardia, but you get an app in your iPhone. You pay for this small monitor here. With you having a symptom, you put your fingers and record an EKG. This has been very helpful for many of my patients that have these sporadic rhythms, but it has to last long enough for you to, open the app, get the monitor. But if you're having something that lasts minutes, it can record it, it's stored in your iPhone, and I have some of my patients email it to me to look at. These are some of the new technology. Of course, the Apple Watch, it has now some of the models records the EKG. And these are specifically designed to look for atrial fibrillation. The Apple Watch focuses on trying to find atrial fibrillation. The problem is that you have to stay away from computers, electronics. You have to have a very steady hand, because it can record a lot of abnormalities that you may think you might have an arrhythmia, but it's not true. But it can be very helpful, and I recommend using this where you're gonna record. Don't keep checking your heart rate all the time. Only use it when you're having symptoms. Again, this is stored in your iPhone. It can be printed, email. People come to the office and show me their iPhone with all the rhythms they have stored, and sometimes they email them to their physician. So what are the causes of arrhythmias? I'm going to start with the rare ones first. I just want you to be aware that there are some people that are born with completely normal heart, totally normal valves, normal arteries, normal heart muscle, but they have a problem at the cellular level with the electrical system. And it's not even the actual fiber, is at the potassium and sodium channels, it's at the cellular level. And they can get dangerous rhythms. These are usually familiar. This congenital lung QT, unfortunately, usually presents with the first family member is usually a cardiac arrest, sudden death. And it usually starts in young family member, dies suddenly. These are fortunately rare, but people can be diagnosed, and usually one member of the family has it. We can do genetic testing for the rest of the family. Another rare disorder, usually also at the cellular level, genetic problem. People can be born with extra pathways. I showed you one of the arrhythmias earlier, that someone had extra electrical connections. However, a lot of people have a completely normal heart, no heart disease, and they might have a primary problem with the electrical fiber. That's their only problem. Sometimes we don't find a cause or why they have the primary problem. And I want to emphasize that with aging, even if you have a strong heart, never had a heart attack, never had heart problems, the electrical fibers scar down, and just with aging, especially age greater than 65 years old, you may develop arrhythmias that you never had before. And we may do a total cardiac evaluation, and there's nothing else wrong with the heart except for the electrical fibers. But so some of this column on your left side of the screen, this is when someone presents to me with frequent palpitations and arrhythmia. I always check, is there anything reversible that may be causing it or may be contributing. So I always check thyroid function tests. Overactive thyroid can cause arrhythmias. Problems with people with low potassium, low magnesium. I've seen women that have menorrhagia, they have severe anemia, they were not aware, and they feel palpitation is because they're anemic. Alcohol is a significant problem, is well known to cause arrhythmias. And it's recommended in women not to drink more than small glass of wine at night at most. and men no more than 2 glasses of alcohol. We know, especially with the COVID pandemic, we see a lot of people staying home and drinking even more alcohol than normal, but alcohol is definitely contributes to arrhythmias. We have an obesity pandemic in this country. It does, obesity causes arrhythmias, affects the electrical system, and the heart can cause many heart problems. So obesity by itself may cause rhythm problems. Patients who have sleep apnea, it also contributes to arrhythmias. Lung disease, asthma, any kind of pulmonary disease, cancer, pneumonias, any pulmonary disease may affect the electrical system. High stress, it may be physical or emotional. I had a few patients that the first time they had a sudden arrhythmia was getting bad news, a very emotional state. And the electrical system, as you know, responds to adrenaline. So stress may contribute, especially if you already have arrhythmias, it could make it more frequent or worse. Now, in terms of the heart problems, hypertension is well known, especially if you had hypertension for years, is one of the main risk causes of atrial fibrillation, problems with the heart failure, problems with the valves, mitral regurgitation, aortic stenosis. Any type of heart surgery, you're up in the chest, you have scars, any heart surgery may damage the electrical fibers. Heart attacks damage the electrical fibers. Again, anything that affects the electrical fibers run all over the heart muscle and around the valves. So anything that can affect that could damage the electrical system. Inflammation, like some people have a viral inflammation of the pericardium, which is the sac around the heart, or actual heart muscle inflammation. So for example, now with COVID-19 pandemic, we're seeing a lot of patients, the patients who are very sick in the hospital. We see a lot of patients with atrial arrhythmias. And problems with the heart muscle, either a very weak heart muscle, it may be congenital, hypertrophic, or thick heart muscle. So any problem with the heart also affects the electrical system. So I want to mention hormones and arrhythmias because this is as with the changes in hormones in different stages, we may see an increase in palpitations, and we sometimes see increase in the number of these. Especially if you already have an arrhythmia, with changes in the hormone levels, the arrhythmia may become more frequent. For example, some women who already have arrhythmias or have premature beats, they can get it more frequently right before they have their menstruation, in the luteal phase, right before the onset of the menses. And because of the changes in the hormones. Estradiol acts as a calcium antagonist. What this means is that it may protect against fast heart rhythm at mid-cycle, but then when as the level goes down, right before menses, the level goes down, and you may have more sympathetic activity, adrenal activity, because of the changes in the hormones. So we have patients that right before their onset of their menses, their arrhythmias can become more frequent. Also, in pregnancy, we may see, again, women who already have premature ventricular beats or premature atrial beats, or already has supraventricular arrhythmias, that with the changes in hormone, they may become more frequent. However, the palpitations during pregnancy are very common, and it's usually due to the normal rhythm going faster, not a sinus tachycardia, because the body has to adjust, the circulatory system has to adjust to the pregnancy. There are significant changes in the circulation, and the heart rate increases. But some women feel that change, but other women do and get a lot of palpitations just by walking. And when we evaluate these women, we do monitors, we find out that actually they having a normal rhythm, but much faster because of adaptation of pregnancy. I done catheter procedures in women who are married, young women who have arrhythmias, especially that one that I show you, the supraventricular, those fast rhythms, right before getting pregnant. They know they were getting pregnant, and they said, I'm taking medication, and I don't want to have to worry about having an arrhythmia during pregnancy or getting more arrhythmia. Most of the arrhythmias, as I mentioned, in pregnancy are benign, but they can cause a lot of anxiety. So we get monitors, we get the echocardiogram, and we make sure that it's benign. And however, we have a group of patients who develop significant arrhythmias. Either I had women who have both supraventricular and some ventricular arrhythmias, and they need treatment. The good news is that we have very good medications that are safe in pregnancy. So I tell some of the women not to worry. We can take care of you through the pregnancy, for the arrhythmia, and these medications do not cause harm to the fetus. I also want to mention about perimenopause and menopause. Again, there's a decrease in decrease in estrogen production may increase the adrenergic activity, and palpitations are a common complaint. But what I have to say is that, like in pregnancy, they're usually benign. It's usually the normal rhythm, going fast and slow. And what I see more frequently is that there's a wide variation. The heart rate might be normal and suddenly it increases and goes fast. So and goes down again. And many women feel that change. Usually no treatment is required, and you can be treated with beta blockers if you have a lot of symptoms. So what are the treatments that we have for these arrhythmias? So there are several basic treatments, which are medications, devices, ablation procedures, catheter ablations. We always like to start with medication. The most common ones are beta blockers and calcium channel blockers. Some of you are familiar with metoprolol, atenolol, carvedilol. These are beta blockers, but these medications help to control the heart rate. And in some, supraventricular tachycardias can actually prevent the arrhythmia. These medications are for people who don't get the tachycardia frequently. I sometimes have them have a prescription that they take only as needed, not every day. But there are other patients that need daily medication to either slow down or prevent the arrhythmia. The other type of medication that we use are stronger drugs, called antiarrhythmic drugs, that have a stronger effect in the electrical system, like flecainide, propafenone, sotalol, amiodarone, ticosine. Well, these drugs are more frequently used in patients with atrial fibrillation, but we use them in patients with other arrhythmias, like supraventricular tachycardia, that also they are effective for atrial tachycardias. Flecainide is the one medication here that is safe in pregnancy, and is usually also used to treat when the fetus, sometimes the fetus are found to have arrhythmias. So it's a very good drug for people with normal heart, and is safe in pregnant women, and we use it for all types of rhythm problems. The reason we don't go right to these medications is because some of them can have potential side effects. I want to mention here, before talking about anticoagulant drugs, the one rhythm that we do give anticoagulants is atrial fibrillation and atrial flutter, because there's a 5-time increased risk of stroke in patients who have sustained atrial fibrillation. This usually doesn't happen if you have a brief episodes. It's usually you have to be sustained more than 24 to 48 hours nonstop. And the people who are at risk for stroke are people who are usually older than 65, have diabetes, hypertension, other heart problems. So not everybody with atrial fibrillation is at risk for stroke. And that's what you need evaluation, because if you're at risk for stroke, the only way to prevent the stroke is with anticoagulant medications. You've seen, I'm sure, advertisement on television, and some of you may be taking these anticoagulants, Pradaxa, Eliquis, Xarelto, which are the ones we commonly use now. Warfarin, you still use, but these are the number one, these are the recommended, considered better than warfarin. And I want to mention that for those patients who have atrial fibrillation, aspirin and Plavix, which are target the platelets, do not prevent clots or stroke in atrial fibrillation. I mentioned this procedure several times. Catheters are inserted in through the veins into the heart, and these catheters record electrical signals. Here it's only showing two, but in reality, we put catheter in the ventricle, we put extra one in the atrium. So the idea is to record the entire electrical system and to pinpoint where the electrical activity is coming from. In this case, this is an ablation of around the pulmonary veins for atrial fibrillation. This records the rhythm, and this delivers a cautery around where the abnormal electrical activity. For other rhythms, these other arrhythmias, one of the most common ones, the supraventricular tachycardia, the catheter goes in this area. In this area, we do a lot of ablations. And so the concept is put the catheters in the heart under anesthesia, sedated, under X-ray guidance, a lot of a lot of mapping equipment to pinpoint so we pinpoint where is the abnormal rhythm, and for 60 seconds, usually cauterize the abnormal fibers so they stops causing the arrhythmia. This is a movie that shows catheters going into the heart. This is the heart beating. These are the two top chambers. This is the aorta. This is the back of the left atrium. These are the veins, that all the chaotic electrical activity around these veins. Catheters are inserted under X-ray guidance. Patient, of course, kept comfortable, sedated, and then burn around the electrical. This is for atrial fibrillation. But for other, and now you don't see all this extra chaotic activity. It's staying inside the vein, it's not coming out to the ventricle. So it's not conducted. We also have devices to treat rhythm problems. And I'm gonna go quickly because we're running out of time. We wanna have people be able to do questions. But so that you know, this is an X-ray of a pacemaker. This is on top of under the skin, it's not inside the body. The wires go through the vein, top chamber, the atrial lead, ventricular. These are for people that the electrical system is not working well. The heart is beating too slow. This is for slow rhythms. And these wires activate the muscle so that people can have normal heart rhythms. And I want to show you another very important device. These are for those people I show you that have dangerous ventricular rhythms that cause a cardiac arrest. It looks similar, but this wire is thicker, and there's one on the top here. This wire also has an important job. It detects the chaotic, dangerous rhythm and gives a shock to the heart before the person has a cardiac arrest. So it's monitoring the heart rhythm sees a chaotic rhythm, gives a shock to the heart, and stops the cardiac arrest. Those are called defibrillators. And here is a fast rhythm, a shock. This is from the recording from the device, and then back to more slower normal rhythm. I want to mention electrical cardioversion for those patients with atrial fibrillation. So a patch is put in front and in the back of the heart, and electrical energy is delivered. Again, this is under anesthesia. The patient doesn't feel anything. This is for people who have atrial fibrillation. They're very symptomatic. Medication is not working, but they're so symptomatic that they need to go back to normal rhythm very quickly. Before I end, I didn't have much time to talk about prevention, but this applies to general for all of us. Many of these rhythms can be prevented if you follow the American Heart Association's Life Simple 7 to have a healthy heart. Manage diet and control your blood pressure, control your cholesterol level, reduce the consumption of sugar, exercise, healthy diet, lose weight, prevent obesity or being overweight, and if you smoke, stop smoking. And in conclusion, palpitations are common and most are benign. There are different types of arrhythmias. Get evaluated by a doctor if you have a prolonged or symptomatic palpitations. Atrial fibrillation is a common arrhythmia, but it's associated with strokes in many patients. And strokes from atrial fibrillation can be prevented with anticoagulation and treatment. A variety of options are available for treatment of arrhythmias. Thank you.
Thank you, Dr. Hernandez. This was fantastic. Just going to share my screen with you right now. So hold on one second. So again, thank you, Dr. Hernandez. This was really informative. And, you know, every day I listen to you talk about your passion as an electrophysiologist is very inspiring. So I want to thank you for your time. We also want to thank the audience for submitting many good questions ahead of time. We have time for a couple. So Dr. Hernandez, if a blood test and cardiogram show no signs or results for palpitations, is it okay to relate it to hormone changes?
I think, as I mentioned earlier, these rhythm problems are very hard sometimes to diagnose. Sometimes we have to use different monitors. That's why they developed that monitor that sometimes be under the skin. So if you are feeling palpitations and you keep having the symptoms, and especially if it's bothering you or giving you shortness of breath or limiting your activity or simply keeping you awake at night, do not give up. There are options, and we can usually diagnose them. Now, as I mentioned earlier, we have those monitors that you can wear for a week and continuously record the rhythm no matter what you're doing. Now we have the one that is inserted under the skin. We have now those others that are the wearables monitors that I show you. And so I would not assume it's hormones. Do not assume anything that is hormones, anxiety, or stress unless you are properly evaluated. And if you know you're having symptoms and your physician is telling you it's nothing, but you need to get another opinion.
Thank you. That I know that your campaign is Be Your Own Advocate, and we appreciate that information. So another question, one of our audience members asked, when you lay down at night, why do you notice palpitations or fluttering?
Yes, this is a lot of my patients ask me that question, and I myself feel also my heart stronger, beating stronger. So what happens is that even though the heart is on the center of the chest, but the left side of the heart is closer to the left chest wall. So if you turn, usually if you turn to the left side, you can really feel your heart very strong, a strong heartbeat. And so if you have any extra beats, any fast beats, it's gonna feel very strong. Any change, sudden change in position, sometimes people feel the heartbeat when they suddenly bend. So any change in position can change, it changes the blood flow and may accelerate the heartbeat. In addition, one of the things that we find is that during the day, we're very busy and active. When we finally lie down and are calm, it's very easy to be aware of your heart rhythm.
Okay, great. Another question was, I have an Apple Watch. How accurate is the heart rate? Mine fluctuates over wide ranges during exercise.
So with all the wearable devices, they can have some false readings because with movement, and you can get some artifacts with movement. And also normally the truth is we don't have just one heart rate during the day. As I mentioned, the heart rate, the electrical fibers are very sensitive to what's going on in the brain, in the body, and it adjusts. So during the day, it's normal to have a variation of the heart rate. What you don't want is extremes. It's not normal to be sitting down, relax, and have a heart rate of 120 or 150. That's not normal. But if you're exercising, these wearable devices might give on and off breathing, depending on how good you have the contact. Usually, sometimes with sweating, the contact is not as good. With the Apple Watch and some of the other wearable devices, when you're recording, it's very important that you are the hand is stable, ideally away from any electrical interference, and because that can give you some false readings.
Okay. Another audience member asked, how much impact does cocoa have on cardiac symptoms?
Cocoa, you mean?
Yeah, cocoa.
Chocolate, okay.
I love the way you say it. I can't say it that nicely.
Well, caffeine and chocolate has caffeine. Actually, the most recent studies have shown that caffeine by itself does not cause arrhythmias. So I do not limit having some coffee or some chocolate. What is important is not to have excessive amounts of caffeine or too much chocolate. And that's even more important in patients who already have arrhythmias. So if you're already getting a lot of beats, palpitations here and there, maybe 1 cup of coffee is fine. But if you start drinking 4 or 5 cups of coffee a day, or drinking caffeinated beverages, or I had a patient once who sat down and ate a whole box of chocolates, and suddenly she got her arrhythmia. And she confessed that she had literally ate a whole box of chocolate in a short time. And so so everything in moderation, but by itself, just having some chocolate and some coffee is not gonna initiate or give you an arrhythmia.
Dr. Hernandez, we had a live question. Knowing how important exercise is, so when you have these flutters and palpitations, is it safe to exert yourself in exercising? What recommendation would you say to this person?
That's a very good question. The most important thing is to make sure you're not having chest pain, shortness of breath, more than the normal that, we are society, we'll get some shortness of breath. Significant shortness of breath, or you start getting dizzy, lightheaded. We have patients that have who stay in some rhythms like atrial fibrillation, or they have premature beats frequently, and they can exercise safely. however, if you have any concerns, what you need to do is you can have a monitor stress test. If you think that you might be having problems, having too many, not feeling well with exercise, or if you're concerned that you may be having rhythm problems, in that case, a simple exercise stress test where you monitor your heart rate, your blood pressure, your EKG, can give you an idea of whether it's causing a problem. But just having a rhythm problem by itself doesn't mean you cannot exercise.
Okay, that's great advice. Thank you so much. Again, thank you, Dr. Hernandez, for taking the time to educate us this evening. The Women's Heart Initiative is now on Facebook. If you can, please join us. It is a public page, but you have to register to be a part of this. We have a lot of women, close to 300 women, who have joined us. It's a great way for women to connect who have heart disease. You also learn about our future events and webinars, and we also post survivor stories. So if you can, Lankenau Heart Institute's Women's Heart Initiative. If you have any questions related to your heart health, ideas for future virtual webinars, or would like more information about the Women's Heart Initiative, you can always email us at Mainline Health Women's Heart at mainlinehealthmlhs.org, or you can call us at 484-476-3WHI. And that concludes our webinar for this evening. I want to thank you again. Thank you, Dr. Hernandez, for joining us, and we wish you all a wonderful evening. Thank you.
Have a good evening.